Hello, everyone, and welcome back to another captivating case review session. Today, we'll delve into fascinating world of abdominal radiology, specifically focusing on large bowel. Our goal is to unravel the mysteries behind various must-know radiology findings and discuss their clinical significance. So, let's get started. Case number 1. Our first case takes us to abdominal topogram, where we observe a dilated loop of gas-filled bowel with distinctive haustral folds. Can you guess the diagnosis? So this is the dilated loop of large bowel and has distinct haustral folds. This is a classic presentation of large bowel volvulus, more specifically cecal volvulus. While an abdominal radiograph can suggest the possibility of this condition, a definitive diagnosis is made using CT imaging. So here's the CT. So this is a coronal CT, which shows this dilated loop of large bowel, presumably cecum, in the right lower quadrant, and there is mesenteric swirling, which is present in the mesentery of the cecum, right there. These are the twisting vessels, suggesting cecal volvulus. So the important finding to consider is whorl sign on the CT imaging is characteristic, and surgery is the treatment of choice. Endoscopic intervention cannot reduce this volvulus as opposed to the sigmoid volvulus, which we will see later. Another important finding here to consider is this dilated loop of bowel has a fold here, and this fold is pointing towards the right lower quadrant. So when the fold is pointing towards the right lower quadrant, that is suggestive of cecal volvulus. Case 2. In our second case, we come across a diffusely dilated loop of large bowel with a characteristic coffee bean appearance. So if we pay close attention to this dilated loop of bowel, it has a fold here, and this fold is pointing towards the left lower quadrant of the abdomen. So this should raise a possibility of a sigmoid volvulus. Again, diagnosis is not definitive on abdominal radiograph, so CT is essential for diagnosing. And on CT, we can see there's this mesenteric swirling in the left lower quadrant, and there's dilated loop of bowel, which is partially seen here, and that's the mesenteric swirling that suggests sigmoid colon volvulus. Sigmoid colon volvulus is 3 to 4 times more common than cecal volvulus, and surgery is not the only modality to reduce the volvulus. Water-soluble enema can also help reduce, and if it is not reduced by enema, surgery is the next best choice. Case number 3. We encounter an abdominal radiograph displaying prominent loop of large bowel with thickened haustral pattern. So this is a large bowel, and you see there's this thickening of the haustral folds right here. What is the diagnosis? Thickened wall and thickened haustral pattern. This typical finding is called colonic thumb printing, and this finding suggests colonic wall thickening, and it is more indicative of colitis. Now, this colitis can be secondary to infection or inflammation secondary to chemotherapy. So the treatment essentially depends on what the cause of colitis is. Moving on, case number 4. So our fourth case involves a patient. The patient has this right lower quadrant pain, and the CT is performed, and the CT shows this diffuse edematous wall thickening of the large bowel, cecum essentially at that level. This is a typical finding of Typhlitis or neutropenic colitis. Various factors contribute to this condition, including ischemia, infection, and neoplastic infiltration. The treatment for neutropenic colitis is non-surgical and remains conservative. Even if you see pneumatosis, that is gas in this wall of the colon here, even then the treatment of choice is conservative and non-surgical. So the etiology is multifactorial, as we discussed earlier. Moving on, case number 5. we have this patient who presented with abdominal pain and has a CT done, axial CT after administration of IV contrast, shows this small valve at its junction with the large valve. So this is terminal ileum, and this terminal ileum is showing diffuse wall thickening and mucosal hyperenhancement. There's some adjacent mesenteric edema as well. So this finding is typical for Crohn's disease in the developed countries. The treatment of choice is medicines initially. The surgery is needed in approximately 50% of cases within 10 years of diagnosis. So eventually, half of these patients do need surgery within 10 years of diagnosis, but the initial treatment of choice is medicines. Moving on. So this is a patient who presented with bloody diarrhea and left lower abdominal pain. And this is a contrast enhanced CT coronal image. As you can see here, there is this diffuse wall thickening of the large bowel, and there's associated mild mucosal internal enhancement. The bowel is not dilated. The visualized segments of small bowel don't seem dilated. The proximal large bowel is not dilated. So this is not obstructive. What we do see is there is this mesenteric increased vascularity here, and then there's mesenteric edema. So these findings are suggestive of colitis. Now, in terms of what the cause of colitis is dependent on the patient's history and also the segment of bowel involved. So in this particular case, this was ischemic colitis with the segment involving from the spleen flexure down to the upper colon. So important thing to consider here is ischemic colitis involving the IMA territory, that is from the splenic flexure to the sigmoid colon, is secondary to embolic occlusion of the IMA. And in patients who have systemic hypotension or a hypovolemic shock, there are two watershed zones which are prone to ischemic colitis. The first one is splenic flexure, that is between the ascending left colonic artery, IMA branch, and marginal artery of Drummond. And the other point is a Sudex point, which is in rectosigmoid colon, that is between superior rectal artery and last sigmoid branch of the IMA that is involved. Moving on, next case. So this patient presents with acute left lower abdominal pain. So this is a CT scan, axial image of a CT scan, and you can see here there is this circumscribed area, and this central area of the circumscribed lesion shows low density, similar to the fat. Subcutaneous fat is same density, mesenteric fat is the same density. So this is a circumscribed area of fat with adjacent soft tissue thickening and then inflammatory changes all around it. And this is in the left lower quadrant. So this is a very typical imaging appearance of epiploic appendagitis. And it can be confused with other causes of lower abdominal pain, such as appendicitis or diverticulitis. So the typical imaging appearance is these epiploic appendagitis are less than 5 centimeters in size, and they are ovoid in appearance. There is central fat density. The etiology is these epiploic appendages hang by the large bowel, and they tend to torse and undergo ischemic necrosis, and that is the cause for epiploic appendagitis. These patients do not have associated fever or leukocytosis. They will have severe pain though because of the ischemic necrosis of the fat in the epiploic appendage. So the treatment of choice is anti-inflammatory agents. Antibiotics are not necessary, neither is surgery necessary. So the conservative treatment with anti-inflammatory agents is usually enough for managing these patients. Moving on. So this patient presented with diffuse right lower quadrant abdominal pain, and the CT scan was performed after administration of IV contrast. And on the CT scan here, we can clearly see there's this tubular structure which is present in the right lower abdomen, and kind of a sac-like structure with a closed end at the end, and it is filled with fluid within it. There's this focal calcification as well. There's no significant fat stranding around this structure. So this is a very typical location for appendix. You can see part of cecum right here. There's small valve right here. And so it looks like this is dilated appendix filled with low density material and has some calcification in the wall. So this is a typical appearance of a mucocele of the appendix. Now, mucocele of the appendix, the treatment of choice remains surgical excision. So the typical imaging appearance is dilated, that is less, it should be greater than 1.3 centimeter in diameter. Mural calcification is suggestive of mucocele. There's absent adjacent fat stranding that we tend to see with appendicitis. The treatment of choice is open right hemicolectomy with excision of the mucocele. Laparoscopic excision is not recommended due to risk of leaving behind a part of the mucocele. Case number 8. So this is a coronal CT image of a patient who presented with right lower abdominal swelling and pain. So this coronal CT image shows that's the cecum right here. There's a tubular structure that extends below from the cecum and is extending it across the abdominal wall into the inguinal canal. And this tubular structure has adjacent inflammatory changes. There's a small amount of fluid next to it. These findings are suggestive of appendix that has extended into the right inguinal canal. The name for this finding is Amyand's hernia. Moving on, case number 9. So this patient presents with chronic constipation and perineal pain. So this is an axial CT image after administration of IV contrast. So these are pelvic bones on both sides. There's this distended structure in the pelvis containing stool. This is the rectum, and there's this diffuse wall thickening of the rectum as well. So these findings put together with history of constipation represent stercoral proctocolitis. As you can see, the stool contains multiple foci of fat, hence stercoral, and there is proctocolitis because there's this diffuse edematous inflammatory thickening of the rectum. So the typical finding is rectal distension, wall thickening, perirectal stranding. These are prone for complications such as ischemia. So this local mass effect from this retained stool can cause ischemia and lead to perforation. So the treatment of choice is prompt disimpaction. Moving on, case number 10. So this is a patient who has a history of rectal cancer, and they presented with the mass for pelvic MRI for staging. So this is a typical appearance of mass lesion. This is the mass here in the rectum, and this is a semi-annular rectal cancer. For the most part, it is confined to the wall of the rectum, except in this part here, it is extruding outside the wall of the rectum, making it a T3 disease. And the treatment for T3 and above disease is chemoradiation, followed by total mesorectal excision. And if the tumor did not extend beyond the outer serosal margins of the rectal wall and was confined to the rectal wall itself, it would have been T2, and the treatment of choice for those patients is directly total mesorectal excision. Thank you so much for attending. That's all for today.